Good evening, all. Welcome to iFocus Online, the 346th episode, 21st in the Oculoplasty module. Today we have with us Dr. Nandini from LVPEI Eye Institute, Hyderabad, to speak to us on systematic evaluation and imaging of the lacrimal system. Dr. Nandini received her MBBS from the Punctal Institute of Medical Sciences, Maharashtra, and post-graduation in ophthalmology at the AJ Institute of Medical Sciences, Mangalore. She has a fellowship in ophthalmic plastic, facial aesthetics, orbits, dacryology, and ocular oncology from the prestigious LVPEI Eye Institute. And currently, she is pursuing her fellowship at the Massachusetts Eye and Ear Infirmary, Harvard Medical School, Boston, USA. She is also a consultant at the Govindram Sekeria Institute of Radiology and a consultant at the Department of Ophthalmic Plastic Surgery Services, LVPEI Eye Institute, Hyderabad. She, to her credit, has more than 75 peer-reviewed publications, reviewer for various national and international journals. She was the organizing secretary of the Transpire with Tears Dacryology webinar and conference, has conducted workshops, live surgical demonstrations, and presented extensively at various conferences. With this very brief introduction, we welcome ma'am to carry on the talk for today.
Thank you, Shubhav. Thank you so much for that kind introduction. I'm just going to share my screen. Just give me a second.
Sure.
Yeah, it's visible.
Yes, ma'am, it is.
All right. So good morning from Boston and good evening to everyone out there. So today I will be talking on the clinical and radiological evaluation of the lacrimal drainage system. So let us just sort of brief up what we learned in the last class. I believe it was anatomy of the lacrimal drainage system. So I'm just going to sort of take you through that briefly, and then we'll move on to the evaluation. So the lacrimal drainage system begins at the punctal orifice, continues as vertical and the horizontal canaliculus. Then it forms a common canaliculus right at the entrance of the lacrimal sac. Then there is a bulbous lacrimal sac, which continues as the nasolacrimal duct, which drains into the inferior meatus of the nose. Right? Now, this is the surgical anatomy. So once we take an incision along the anterior lacrimal crest and we separate the sac, this is what we see. So this is the anterior lacrimal crest. The bone below that is your lacrimal sac fossa, and you can reflect the sac all the way up till the posterior lacrimal crest. So between the anterior and the posterior lacrimal crest is your lacrimal sac fossa. Now, if you take a cross section through the lateral wall of the nose, this is what you would see. So this is your superior turbinate. The space below that will be your superior meatus. This is the middle turbinate. The space below that is the middle meatus. And this is the inferior turbinate. And the space below that would be the inferior meatus. Why this is important? Because we need to understand the lacrimal sac is located somewhere out here. That is in front of the middle meatus or the middle turbinate. And then your nasolacrimal duct will move behind this and then open in the inferior meatus. So here you see this probe coming out. So that is behind the inferior turbinate or in a space that we call the inferior meatus. Right? So now talking about the clinical evaluation of the lacrimal drainage system, the first most important step is to take a meticulous history. Now, when we talk about history, what do we ask? We ask about the duration of epiphora. That will give us an idea whether we are dealing with a congenital epiphora, a developmental epiphora, or an adult onset epiphora. Discharge. What type of discharge is there? Whether it's a very mild mucoid discharge, whether it's thick white mucoid discharge, whether it's a mucopurulent discharge. So that will give us an idea whether we are dealing with something that is outside the lacrimal system or coming from a blockage in the lacrimal system. Suppose there is a pathology which is outside the lacrimal system, you will mostly have a watery discharge, which will have very fine mucoid strands to it, may not have really mucoid discharge. But in case of an obstruction, nasolacrimal duct obstruction, if it is being drained regularly, you will get a mucoid discharge. But if it is infected, you will get a mucopurulent discharge. So the kind of discharge will actually give us an idea as to what kind of pathology are we dealing with. Then we need to ask about any history of swelling in the lacrimal sac area or redness in the lacrimal sac area in the past. That will give us an idea whether the patient has been suffering from acute episodes. And now what we are dealing with is chronic or an acute disease. The other important history that we need to take is any sort of topical medications, for example, anti-glaucoma medications or 5-FU, because we know all of these drugs are known to cause canalicular obstructions and different kind of stenosis in the canaliculus as well as in the nasolacrimal duct on long-term use of these medications. So we need to ask about history of medications. Now, skin diseases is something that we often miss when we are evaluating the lacrimal system. But skin diseases like lichen planus or psoriasis around the eye can actually cause a lot of epiphora. Lichen planus is actually known to cause canalicular obstructions or canalicular stenosis. So it is very important to ask about any skin diseases for which they are taking medications or if they've consulted a dermatologist for the same. Even periocular eczema, dermatitis can cause reflex epiphora. So all this history is actually going to help us evaluate whether the epiphora is because of the lacrimal system or whether it is reflex epiphora. Now, once we have taken a meticulous history, let's move on to the facial and periorbital evaluation. Before we do anything invasive in the form of lacrimal irrigation or syringing, we should first do everything that is non-invasive. So first, we always look at the facial and periorbital evaluation. So here, the picture on the left shows us that there is a stent prolapse in the palpebral fissure area, and that is causing epiphora post-surgery. So only when we look at the facial and the periorbital area will we be able to pick this up. Now, in the second picture, you see a small kid with a bluish swelling in the lacrimal sac area. Of course, we know that this is dacryocele, and we need to take this child up for probing immediately. Now, other thing that we need to look at is lid malposition. So in the first picture on the left, you see that there is an ectropion. However, medially, if you look at the punctal area, there's no punctal ectropion. But in the second picture, you will see that there is a complete lid ectropion involving the medial as well as the lateral areas. So here, what is the difference in the epiphora? In the first patient, the patient will have epiphora, of course, because the drainage of the tear actually takes place from the lateral, and then it moves towards the medial part of the eye, and then it goes into the lacrimal drainage system. But here, since that is disturbed, even though the puncta is in position, the patient will still complain of epiphora. However, the patient who is on the right side will complain of epiphora even more as compared to patient on the left. So when we do lid examination, we should always check for lid laxity, because a lax lid will have a weak lacrimal pump function. So when we look for lid laxity, we can do all of these tests like the pinch test, snapback test, lateral distraction test, and the punctal grading. Now, this is something that you've already covered in the eyelid module, so I'm not going to get into the details of these tests, but these tests will tell us about the lid position, and the lid laxity will help us determine the strength of the lacrimal pump function. And that is very important when we look for epiphora. Now, after we have looked at the periorbital anatomy, it is very important to look at the lacrimal drainage system per se. And the first step of any lacrimal drainage system evaluation starts with looking at the puncta. Now, what is a normal puncta and how does it look like? Well, if you look at 50 patients having no epiphora, just look at the puncta who come to your clinic, and that is when you will know this is normal punctal anatomy, and anything that is away from that is abnormal, because it's a very small area. So you look at the opening, you look whether you can see a part of the vertical canaliculus through the punctal opening, and you look at the peripunctal area. you look for any inflammation in the peripunctal area. This is very important because this will help us determine that at least at the beginning of the lacrimal drainage system, there is no abnormality. It is also important to note the position of the puncta in relation to the ocular surface. So when you actually look at the eyelid, the puncta is hugging the ocular surface. It is touching the ocular surface. And that is very important for your lacrimal pump function to get activated when the eyes are closed. So in case, so this was a patient who presented with epiphora since many years. So he is a teenage boy and he's having epiphora since he was 3 or 4 years old. Now here, when you look at his nasal bridge, you see that the nasal bridge is elevated, kind of. And then when you look at the position of the puncta, look at the separation of the puncta and the ocular surface. Now, this is what we call the centurion syndrome. Here, what happens is the medial canthal tendon is a lot anteriorly attached. And that is why the puncta does not oppose with the ocular surface. And therefore, the tears will accumulate in that gutter which is formed, and that will cause epiphora. So the treatment for this would be to actually go in surgically and push the medial canthal tendon posteriorly so that the puncta falls in place, and then the lacrimal pump function will work as it is supposed to work. So it is very important to look at the puncta. Now, when you're looking at the puncta and you see this kind of watery discharge coming out from the punctal orifice, this is a case of chronic canaliculitis. When you actually press on it, you will get mucoid discharge or flakes, yellowish flakes coming out from the canaliculus. But if you don't look at the puncta itself, then you're going to miss such cases. In cases with canaliculitis, you will see that in the medial part of the eyelid, there will be swelling, redness, and sometimes you will be able to appreciate a swelling of the puncta itself. And when you press on it, you will get discharge or yellowish flaky material from the canaliculus. Now, if we don't really look at the periorbital and the punctal area, we will again miss this as the reason for epiphora. So it is very important to look at the peripunctal anatomy or periorbital anatomy. Now here, what do you see? The picture on the left, just look at the swelling of the conjunctiva. So there is a lot of conjunctivochalasis, which is actually falling over the punctal orifice and blocking the punctal orifice mechanically. Now here, there may not be any obstruction to your lacrimal drainage system, but the patient will complain of epiphora because there is a mechanical blockage of the opening of the lacrimal drainage system. Here again, you will see that there is a megalocuruncle. The curuncle is very big, and it is actually mechanically blocking both the superior and the inferior puncta. Now, when this happens, because of the mechanical blockage, the tears do not flow normally inside the lacrimal drainage system. And that is what causes epiphora in these kind of cases. So it's very important to look at the curuncle, the plica, and the surrounding conjunctiva, whether that is actually mechanically blocking the orifice. And this is usually seen, say, from 4th to 7th decades of life. Now, once you've completed the periocular examination, we move on to the examination of the eye per se. So especially in kids, it is very important to look at tear meniscus height because they are not going to let you do any of the invasive tests. So any patient, any child presenting to you with, not only child, you can do this, you can look for it in adults as well, but it's very important in a kid. So when they come to you, just look at the normal eye versus the abnormal eye. You will, if there is a congenital nasolacrimal duct obstruction or say an epiblepharon, which is where the lashes are directed into the ocular surface, you will see that the tear meniscus height is actually raised on that side as compared to the other side. The other two important tests is T-Butt and Schirmer's, that is to evaluate dry eye, because dry eye can cause reflex epiphora or something we call as hyperlacrimation. Hyperlacrimation, the lacrimal drainage system is going to be normal, but the patient is going to complain of epiphora. So we need to rule out dry eyes, especially in about 5 to 6 decades of life. The other important test in kids would be fluorescein dye disappearance test. Even from a residency point of view, this test is very important as to how to perform and how to interpret this. So you instill 2% fluorescein into the inferior cul-de-sac, and then you just observe for 5 minutes. The child or the patient, adult patient, just blinks normally as the patient is supposed to blink. At the end of 5 minutes, just look at the amount. You can use a blue filter from your indirect ophthalmoscope or from your slit lamp, and then evaluate the level of the tear meniscus, so the amount of fluorescein seen in the tear meniscus. So if in case it's a normal drainage, at 5 minutes, you will not be able to detect any fluorescein dye in the tear meniscus. So that is the picture on the right. If you see, you can see no amount of dye that is appreciated here. Whereas the picture on the left shows residual dye at the end of 5 minutes. So a delayed dye disappearance test is actually indicative of something happening in your lacrimal drainage system. Now coming to ROPLAS, or regurgitation on pressure on the lacrimal sac. Now here, why I've put this video is because most of the times we end up pressing at the wrong place. Now, if you actually look at the name, it is regurgitation on pressure on the lacrimal sac. So if we do not press on the lacrimal sac, it is not going to give you a positive result. So it is very important to go just medial and inferior to the medial canthus and press it in that area, and then you will see regurgitation. Now, a regurgitation of a mucoid or a mucopurulent fluid on pressure on the lacrimal sac indicates that there is some kind of obstruction in the nasolacrimal duct, or there is accumulation of water or tears in the lacrimal sac, maybe due to atonicity or due to failure of the lacrimal pump function. And that is why it is collecting in the lacrimal sac and has become mucoid or mucopurulent because of infection, and that is regurgitating out on pressure. So it is a very important test which tells us of an obstruction that is present within the system. Now coming to syringing, or as we call it, irrigation of the lacrimal drainage system. Now here it is very important to do it in the correct way in order to interpret correct results. So when I'll just take you through the video. So this is a video of a child who's under anesthesia, but essentially when you do it in the OPD, the procedure is going to remain the same, except that we wouldn't need to dilate the puncta. So here we are going to dilate the puncta because this is a child in whom we had done probing, and I'm just going to take you through this. So whenever you're doing irrigation, prefer to do it from the upper drainage system. You divide the eyelid into medial 1/3, middle 1/3, and lateral 1/3. Now at the junction of the medial and the middle third, you lift the eyelid along with the eyelashes. Now you can see the puncta clearly, and you can see the canalicular area clearly. This is very important so that you avoid damage to the lacrimal system. Now first you go in perpendicular and then turn your dilator completely parallel to the lid margin. You look at this lid margin over here and you look at the punctal dilator, they are completely parallel to each other. And when they are completely parallel, you can actually see the dilator going into the canaliculus. You know that you're not causing any damage. And the stretch on your lid will actually make the canalicular pathway extremely straight so that you avoid any damage. Now, here we are using a 23 gauge cannula, but when you're doing it in the OPD, you will use a 27 gauge straight cannula. Now, we prefer using a straight cannula because we want to avoid damage to the walls of the canaliculus, right? So, and use a 1 ml syringe and not a 5 ml or a 10 ml syringe, because you do not want an undue pressure of fluid in your lacrimal system. Your lacrimal system is very small. Now, again, you go in perpendicular and turn completely parallel to the lid margin. Once you're parallel to the lid margin, the needle will just automatically flow in and you will hit the bone, getting a hard stop. So very important over here is two very important things. One is you have to stretch the eyelid such that your vertical and your horizontal canaliculus align and they become straight. When they become straight, you will avoid trauma to your lacrimal drainage system. and the needle will automatically go in, and you will not have to literally force it in, and you will get better and correct results. The second important thing is, first, when you make an entry into the lacrimal system, it is, if this is your lid margin, you will enter perpendicular, and then you will turn completely parallel to the lid margin. When it is parallel, you are in direction of the canaliculus, and that is the direction with no resistance. So these two are the most important things when you do syringing. And make sure you're using a straight cannula. If you have a curved cannula, which is available, of course, the ones that are available in the market are always bent or are slightly tilted. You can actually tilt them back and make it straight and then use it. And do not use a 5 ml or a 10 ml or a 2 ml syringe. Why? Because that actually creates a lot of force into the lacrimal system. And so even when you don't have an obstruction, you may see a little bit of regurgitation, which will confuse you. So it is better to use a 1 ml syringe and do irrigation very, very slowly. All right. So now let's come to the findings. So from a residency point of view, you need to understand what is hard stop and what is soft stop. So a hard stop is, so look at the first picture here. So when you go in with the syringe and you directly hit the bone over here, that is the nasal bone on which your lacrimal sac is resting. That is your lacrimal sac fossa. So over here, when you directly hit the bone, you will get a hard stop. That means there is no canalicular obstruction and you have reached the sac. Whereas now you look at the fourth picture. Now here, when you're actually inserting the syringe, because there is a common canalicular obstruction, you will not be able to hit the bone. And here you will get something called as a soft stop. Now, how do you recognize a hard and a soft stop? Well, you just have to keep doing syringings again and again to finally understand what is a hard stop and what is a soft stop. Never go and hit the bone behind, because that way you will damage the mucosa of the lacrimal sac. So once you understand what is a hard stop and a soft stop, it sort of gives you an idea as to what you're looking at. And then you start irrigating slowly. So here in picture, now let us go through each of these pictures one by one. So here you're irrigating through the inferior system, and whatever you're irrigating is actually felt by the patient in the nose and the mouth. That means it is a patent passage. Coming to the second picture, here you are irrigating through the upper lacrimal drainage system, and it is freely flowing into the nose. That means it is a normal passage. Now coming to picture number 3. Now here it is very important. Now here you are actually irrigating through the inferior system. Now the patient is feeling most of the fluid in the nose, but you are also able to see a little bit of regurgitation. So here your interpretation would be there is a probable stenosis of the nasolacrimal duct. That could be one of your findings here. Or the other thing could be that you've actually forced the fluid in and there is too much of fluid, and therefore some of it has regurgitated. So you can call this as partial obstruction, or you can call it as nasolacrimal duct stenosis. Now look at the third picture, but on the left side. Now here you are irrigating through the inferior system. Just maybe a drop or two is actually felt in the nose, but most of it is regurgitating out. So this is a case of partial obstruction or gross nasolacrimal duct stenosis. Now coming to the fourth one. Here you are irrigating through the lacrimal drainage system. You're feeling a soft stop, but there is no regurgitation outside. That means you're looking at stenosis of the common canalicular junction. Whereas in the picture on the left-hand side, you're irrigating through the inferior system and the entire amount is regurgitating back. Here, it means that there is a common canalicular obstruction. So you have to differentiate between a stenosis or a partial obstruction versus a complete obstruction. Now let us look at the number 5. So you are going in with your syringing cannula, you feel a soft stop. Then you irrigate, and all the thing comes back from the same side, from the same punctum. That means you're looking at an inferior canalicular obstruction. Now you go in through the upper canalicular system, you feel a soft stop, and everything just regurgitates from the same punctum. That means you're looking at an upper canalicular obstruction. Now, whenever you have a canalicular obstruction, always measure whether it's a proximal obstruction, mid obstruction, or distal obstruction. How do you do that? So take a forceps. Now you have put your syringe inside, hold the syringe at the punctal orifice, and hold the amount of syringe that has gone in at the punctal orifice and bring it out and measure the amount that was inside. That will give you whether, if it is less than 2 millimeters, it is proximal obstruction. Somewhere between 2 to 6 millimeters, it is mid obstruction. More than 6 millimeters is distal obstruction. Now, this is important when you decide the management for canalicular obstructions, I think, which will be covered at a later date. So I'm not going to speak on the management bit. Now, coming to picture number 6. So as I said, these from picture 6 to 8 are all different types of canalicular and punctal obstructions. So once you measure it, you would know that whether it's a proximal, mid, or a distal obstruction, and that will help you determine how to manage it further, right? So coming to the last bit of clinical evaluation, now you've done the syringing, but it doesn't end there. You should always do an anterior rhinoscopy. Just put an endoscope along the floor and just look at the inferior, at the floor, at the turbinate, that there is nothing, there's no mass, there's no swelling. And if at all you're doing probing, of course, look at the probe that is coming into the inferior meatus. So McNabb had actually described a very logical sequence, which is what we covered right now. So whenever you have to do a clinical evaluation of your lacrimal drainage system, always follow this logical sequence. It is called as McNabb's logical sequence, where you initially take a directed history for epiphora, exclude the causes of reflex tearing, make sure the puncta are normal, assess lid laxity, palpate the lacrimal sac, then you syringe the lacrimal system. If patent, you will perform FDDT and Jones test, and then you examine the patient's nasal cavity. And once you do all this, your evaluation of lacrimal drainage system is essentially over. Now, I haven't spoken about Jones test because we do not really do it, but from a residency point of view, it is important to know what is Jones test, and that is why I've just put it here. So whenever you have a partial obstruction, you want to know whether there is a problem in the lacrimal system or it is hyperlacrimation. That is when you perform Jones dye test. So there is a Jones dye test 1 and there is a Jones dye test 2. So what do you do first? So you instill some fluorescein dye in the inferior cul-de-sac, and at the same time you will put a cotton plug which is dipped in xylocaine so that you anesthetize that area in the inferior meatus. Now, it is very important that you place it in the inferior meatus. If you don't place it there and you put it anywhere in the nose, you're going to get a negative test no matter what you do. So that is why it is important you put it along the floor. And how do you know that you've put it along the floor? Imagine this is your palate. Your floor is along the palate. So you will go straight in, right? So you put it along the floor in the inferior meatus and leave the fluorescein dye for 5 minutes, just like how you do for fluorescein dye disappearance test. At the end of 5 minutes, you remove the cotton plug and see whether it is soaked in the dye or is it not soaked in the dye. If it is soaked in dye, that means your lacrimal drainage system is perfectly normal and it is probably primary hyperlacrimation or something that is causing reflex tearing that is causing the epiphora. And if it is negative, that means the dye has not come into the inferior meatus. That means there is some problem in the lacrimal pump or there is a partial obstruction which is not allowing the dye to reach the inferior meatus. Only and only when you have a negative test, you will perform the Jones dye test 2. Now here again, you will put the cotton plug inside in the inferior meatus and now you will do a lacrimal irrigation. So whatever dye was there in the inferior cul-de-sac has actually gone into the system, but it has not really reached the inferior meatus. So now you will do an irrigation of the lacrimal system, which is again, remember, do not use a 2 ml, 5 ml, 10 ml syringe because you do not want to put that much fluid into the lacrimal system. Your lacrimal system is very small. It cannot accommodate that much fluid. So use a 1 ml syringe and very slowly you irrigate. Now, if there is, when you irrigate and the fluorescein reaches your cotton bud that you've placed inside the inferior meatus, that means there is a partial obstruction. But when you irrigate a little amount and you still don't see any dye in the lacrimal system, that means everything is collecting into your lacrimal sac. So there is a lacrimal pump failure or an atonicity of the lacrimal sac that is causing the accumulation or that is causing epiphora. So that is all about Jones test. We do not really need to do that because syringing almost always gives us the answers that we are looking for. So we do not really perform this, but from a residency point of view, it is very important to know what is Jones test, and it is one of the important steps in evaluation of your lacrimal drainage system. So with this, we come to the end of the clinical evaluation of your lacrimal drainage system. Any questions do we have so far on the clinical evaluation?
Ma'am, I think we can take it towards the end because we'll be collecting it from the social media portal.
Yeah, fine. So then I'll just go ahead with the second part, that is the radiological evaluation. Now here, there are three main, three main things that we can do to radiologically evaluate the lacrimal drainage system. But it's important to know that it is not always necessary, and we need to do it only and only when in certain conditions, and we will talk about it as we move ahead. So the three ways that you can evaluate your lacrimal drainage system is by using CT scans, Dacryocystoscintigraphy, or Dacryoscintigraphy. Now, Dacryoscintigraphy is not something that we really practice. One is because it's not really available, and second, it doesn't really give us that good results as we expect. A Dacryocystoscintigraphy will give us much better results, is much more simpler to do, and that is why we would prefer to do it prefer to do a Dacryocystoscintigraphy than do a Dacryoscintigraphy. Also, Dacryoscintigraphy is much more expensive. So I'm going to combine CT scans and Dacryocystoscintigraphy in one and tell you how to evaluate the lacrimal system, and then in the end we will talk about Dacryoscintigraphy. So when we talk about DCG, it started with a conventional Dacryocystoscintigraphy that is using X-rays. And it was first done by Ewing in 1909. He used bismuth subnitrate as contrast to visualize a lacrimal abscess on an X-ray. Now, why was it not suited? Because, of course, whenever you do an X-ray, there's a larger radiation dose, and look at the picture on the left. There is so much overlapping of structures that it is almost impossible to really delineate the lacrimal system. Of course, we can make out that probably there is an NLD obstruction on the right side, whereas on the left side, it is draining into the inferior meatus, as you see over here, but it's not very clear. So what was done later was the picture on the right. This is a macro DCG. A macro DCG is where all the bony anatomy is actually blurred off. And that is when you get a nice, so you'll see the puncta, the vertical and the horizontal canaliculus getting into the lacrimal sac and then draining all the way to the inferior meatus on the left side. Whereas on the right side, you see there is an obstruction. You can see the canalicular pathways absolutely clearly, but you see a kind of stenosis at the common canalicular junction, but it gets into the lacrimal sac, and then there is an obstruction somewhere in the mid nasolacrimal duct. So yes, it was useful, but doing a macro DCG meant a larger radiation dose, and therefore we moved on to better modalities. So this picture that you see is of an MR DCG or a MRI Dacryocystoscintigraphy. So what is the importance of MR Dacryocystoscintigraphy? One is it gives us the functional component. That is, what is the tear transit time? So when done on normal volunteers, we found out that around 340 seconds is the amount of time it takes for a normal tear to transit from the ocular surface into the inferior meatus of the nose. Now, of course, whenever you're doing an MRI, it is a long process. All right. And it does not give us any bony details, which is very important in any lacrimal case, because we are dealing with, or any surgical procedure that we undertake is going to deal with the surrounding bony anatomy. And therefore, we need a lot of bony details. Now, here again, when we digitally subtract when we use a digital subtraction MRI, it will give us a much better picture of the lacrimal drainage system. Like if you look over here, you will see that there is actually stenosis, which is happening in the proximal nasolacrimal area. And that is what is probably causing epiphora. Over here, you will see stenosis happening at different places at somewhere in the mid nasolacrimal duct area and again in the distal nasolacrimal duct area. Now that stenosis, whether it is a stenosis or it's a dacryolith, now that is not something that we can make out on this, but there is some sort of an obstruction that is happening, which is partial, is what we can make out when we look at digitally subtracted MRI images. All right, so that gives us a better idea of the soft tissue component. But if we want to look at the soft tissue as well as the bony component, then we need to do something called as a CT-DCG, or a computer tomography dacryocystography. Now, this is one of the most common modalities that is used to evaluate the lacrimal system, and hence we will talk about this a little more in details. So this is a 3D reconstructed image with the dye in place. You can see that the dye is easily transiting into the inferior meatus on both the sides. So this is how a normal lacrimal drainage system would appear on a 3D reconstructed image. But whenever we are doing a CT-DCG, one very important advantage that we get is the parasagittal cuts. Now, when you look at the parasagittal cuts, you can actually image the entire tract of the nasolacrimal duct into the inferior meatus. Now, this will give us the bony nasolacrimal duct as well as the soft tissue nasolacrimal duct, and we can see it nicely draining into the inferior meatus. So these parasagittal cuts are very, very important in CT scans, in CT-DCG, to evaluate the lacrimal drainage system in total. So why do we do DCG? When do we do DCG? So we do it when we want to visualize a lacrimal drainage system, when we want to know the position of the sac or the size of the lacrimal sac with respect to the bony landmarks, when we have cases where you have a swelling which is away from the lacrimal system, but it is connected to your lacrimal system, like in cases with sac diverticula, where you have a partial obstruction, you think that there are mucopeptide concretions, like how you saw in MRDCG image, the digitally subtracted image. It could be a mucopeptide concretion, or that is also called as dacryolith, or it could just be stenosis of the system. But how do you know that? So for that, you can use a DCG. If you want to know that there is any functional obstruction of the tears, if there is any lacrimal sac mass lesion, in cases with trauma, in cases with partial nasolacrimal duct obstruction, and in cases where there are masquerades, like there is a swelling in the lacrimal sac area, but when you do syringing, it is completely patent. So the swelling can actually be away or just attached to the lacrimal system, but not really involving the lacrimal system. So here you will have to put in the dye so that you can differentiate the lacrimal system from the mass lesion. And that is one more reason why you would perform DCG. So these are few indications why you would do a radiological examination. So what dye is used? Ideal dye should be radio-opaque, homogeneous, non-irritant, non-toxic, should have optimal viscosity so that it just doesn't flow down and it stays in the lacrimal system while we are filming it, and should be free of adverse reaction. What we use over here is an iohexol injection, which is diluted with 50% normal saline and then is injected into the lacrimal system. Or in cases with MRI, it is just put into the inferior cul-de-sac and the patient is asked to blink normally and images are taken every minute. For a CT-DCG, a single image is taken after injecting the dye into the system. Yes, you can also use the drop method, but a drop method for CT scan is not really preferred because it will involve a lot of radiation exposure. So just injection method for CT scans and a drop method for MRI should be more preferable. Now, let us understand how do you see the lacrimal system on a CT scan. So these are coronal images. Now, when you look at serial coronal images, firstly, whenever you ask for any orbital CT scan, make sure you mention that they are 2 millimeter cuts. Because if you do not mention that, the normal brain CT scans or MRI images are actually 5 millimeter cuts. And when you have 5 millimeter cuts, you will automatically just miss the entire anatomy of the lacrimal system or any other part of the orbit. So whenever you're asking for an orbital scan, always make sure you ask for 2 millimeter images. And if you want to look at the optic nerve at the apex, always ask for 1 millimeter images. So this was just apart from the lacrimal system, but it is very important to not make sure that these are 2 millimeter cuts. So you're looking at the anterior most cut, and then you move 2 millimeters behind, and then 2 millimeters, and then 2 millimeters. So somewhere around 10 millimeters behind the anterior most cut, you will start appreciating the lacrimal sac fossa. Can you see this? The first image on the left on the lower side. If you can appreciate my arrow, this is the beginning of the lacrimal sac fossa. Then you move 2 millimeters away. Now the lacrimal sac fossa is very well formed on both the sides. You move 2 millimeters away and you can see the bony nasolacrimal duct that is forming. You move 2 millimeters away and then it's over. So you need to understand that somewhere from about 8 millimeters from the anterior most point to about 15 millimeters behind the anterior most point, you will see the lacrimal drainage system. And this is the place where you will evaluate the lacrimal drainage system, either on a DCG or on a CT scan when you want to evaluate it in cases with trauma. So similarly, these are axial images. Now, axial images, so just coronal images go from front to back, whereas axial images go from inferior to superior, right? So when you image the most inferior portion, you can see this is the nose, these are the nostrils, and you will see the maxillary sinus. Then you go 2 millimeters inside, you will go a little bit more superior along the nose, and you will start seeing the maxillary sinus in detail. And your nose, you will start appreciating the details inside, that is the septum and the lateral wall just beginning to form. So you move about, again, 8 millimeters inside. You look at the last picture on the upper row, and you will see the nasolacrimal duct, which is beginning to appear. So as you're going superior, along the floor, the opening of the nasolacrimal duct, which is in the inferior meatus, will begin to appear on either side. So this is your nasolacrimal duct opening on both the sides of the nostril in the inferior meatus. As you move more 2 millimeters superior, you will be able to appreciate the entire passage of the nasolacrimal duct within the nasolacrimal canal until you no longer appreciate it. This is where your lacrimal sac fossa is located. So again, somewhere from 8 millimeters to 15 or 16 millimeters is where you will see your lacrimal system from the floor or from the inferior most image, right? So now that we understand how to look at the lacrimal system on the CT scan, let us look at the CT-DCG images. So these are 3D reconstructed images of the lacrimal system. So look at the first image now. On the left-hand side, when you are actually syringing, you can see both the canalicular pathway. You can see a nice lacrimal sac, which is draining into the inferior meatus. Whereas on the right-hand side, you will see an abrupt discontinuation at the sac duct junction. That means there is some something that has happened at the sac duct junction and the dye is not going anywhere beyond that. But also what is important, look at the bone in the lacrimal sac fossa area. So there is already an osteotomy which is present. So this is a case where a DCR has already been done. However, it had failed. And when we did a CT-DCG, we can see that the sac is nicely dilated. It is in place. A bony osteotomy is already present. And when you go in endoscopically, you will be able to appreciate that it is if you actually press on the lacrimal sac, that it is only a soft tissue scarring on the inside. And if you just release the soft tissue scar, you can actually achieve the patency, or you can create a patent ostium. Now, these are the various views that are available on a 3D CT DCG image. Very, very important, because if you look at the middle picture, in a straight image, you will not be able to locate whether the sac is in position or not. But when you actually move the skull from right side or left side, you can actually see the position of the sac in relation to your lacrimal sac fossa. And that is very important, especially in cases with trauma, because in cases with trauma, sometimes because of the impact of the trauma, the sac actually moves from its position. And that is where these scans are most important, so that we know where exactly we are supposed to create the osteotomy in order to reach the sac. All right, so moving on to the parasagittal images, as I was explaining earlier, is the most important image when you're looking at a CT-DCG after a 3D reconstructed image. So here again at around 8 millimeters, you will start seeing the nasolacrimal duct in its entirety. That is from the beginning of the nasolacrimal duct till it drains into the inferior meatus. This will give you the entire tract of the nasolacrimal duct, and it will tell you whether there is damage to the bony nasolacrimal duct also, or there is no damage. Right? So let's discuss a few examples so that we understand what we have seen so far. So here you see the swelling. You see the swelling is actually much, much more away from the lacrimal sac fossa itself. So here it's not only a lacrimal sac swelling, but we are looking at something that is involving the sac and is causing an enlargement of the sac. And when you do a CT-DCG, you look at this. This is the normal sac, which is also dilated. I'm not saying that it's normal, it's dilated. And then you see this diverticular cavity, which is coming out from the sac and is forming a swelling, which is inferolateral to the sac. Now, this is important because these cases you will never go in endoscopically. These are the cases where you have an anterolateral diverticula, where you should go externally so that you get the entire diverticular cavity. Now, when you look at the parasagittal images, you see that there is also an obstruction that is happening at the proximal end of the nasolacrimal system. So this is a post-trauma case. So because of the trauma, there was an obstruction of the nasolacrimal duct. There was also some damage to the lacrimal sac, and that caused the diverticular cavity to form. And this is a very useful information which we will get only and only when you do a CT-DCG. Now look at the last case and look at this case. Again, both the cases, you can see the swelling was extending above the medial canthal tendon. So it's not that you can really say that this is not a lacrimal sac swelling when the swelling extends above the medial canthal tendon. It can extend above the medial canthal tendon. Here also the swelling is in the lacrimal sac area, but a little bit away from it, and it is extending above the medial canthal tendon. When you do irrigation, it was patent. So then we went ahead and we did a CT-DCG. And what we saw was on both the sides. So whenever you do CT-DCG, you do it on both the sides. The patient did complain of epiphora on the other side as well. So here we went ahead, we did the CT-DCG, and this what you see here is the sac, but you will also see that there is something really pressing on the sac in this area. And this swelling is actually separate from the lacrimal sac. Look at the swelling over here in the first picture and look at the size of the sac here. Now it doesn't really correlate, does it? It doesn't. So there is something that is actually pressing on the lacrimal system, and that is causing the little bit of epiphora which is happening. And the swelling is actually away from the lacrimal system. When we did a biopsy of the swelling, it actually came out as follicular lymphoid hyperplasia of the orbit, and it had nothing to do with the lacrimal system. Of course, on the left-hand side, there was a nasolacrimal duct obstruction, which the patient then underwent DCR for. Now, this is a trauma presented to us after RTA. Now, look at the position of the lid, which is, of course, not normal. It is causing a medial inferior ptosis, and on the lateral canthus, you will see a lot of scarring. Now, here we went ahead, we did a CT-DCG, and what you can see over here is the sac is dilated and it is sort of inferiorly pushed and is not really in the lacrimal in the position. So this is your lacrimal sac fossa. All right, and you look at the sac. Where is it? It is actually pushed inferiorly and posteriorly into the orbit. It is not in its normal position. So when you, in these kind of cases, when you are looking at doing an osteotomy, you will actually be creating an osteotomy which is much beyond the lacrimal sac fossa and almost into the inferomedial part of the orbit. And that is why you need to know the position of the sac in any case with trauma. And therefore, a CT-DCG is a must in these kind of cases. Whereas on the other side, you can actually see the sac sitting nicely in the lacrimal sac fossa, right? And then draining into the inferior meatus. So that gives you, so when you turn the skull, it gives you a relative position of the sac with respect to your lacrimal sac fossa, which helps you determine the positioning and therefore the kind of surgery that you want to undertake. Right, now this is another case of post-trauma nasolacrimal duct obstruction, or as we call it, a secondary acquired lacrimal duct obstruction, or SALDO. Now here, what are the important things that we get from a CT scan? One, you see the amount of damage that is there in the glabular area. Then you see multiple plates and screws in the maxillary area. But apart from that, when we have to look at the anatomy of the from a surgical perspective, look at the damage over here. This is the cribriform plate, the horizontal and the vertical part of the cribriform plate. And you can see that because of the trauma, the cribriform plate has moved lower, and it is actually sitting right in front of where our lacrimal sac fossa is. So here, we have to be very careful when we are doing the surgery so that we do not damage the cribriform plate, and therefore there is no CSF leak or damage to the brain tissue. So a CT scan will help us evaluate the relative position of the lacrimal sac in relation to other bony structures in and around the lacrimal system. When we do a CT-DCG, you will actually see that the sac is really shrunken on the left-hand side, whereas on the right-hand side, you will see that the sac is dilated and there is an obstruction which is happening somewhere at the sac duct junction or just about below it. So and you can also see that it is relatively moved superiorly. So we know now the cribriform plate is somewhere over here, and this is the sac right over here. So if we do an aggressive osteotomy in this case, we will end up causing a CSF leak and herniation of the brain tissue if we take out too much of the bony surfaces. Therefore, we have to be very careful in these kind of cases. Again, why is a CT-DCG important? So this was a patient who presented to us after having undergone orbital fracture repair, a maxillary and a facial fracture, as well as an orbital fracture repair. So look at the image C. Can you see this floor plate actually extending below the lacrimal sac? And what had happened here was, because the plate was actually inserted between the lacrimal sac and the nasolacrimal duct, it caused a mechanical and a shearing tear at the junction of the sac and duct. That caused the epiphora. So this is what we call hardware-associated nasolacrimal duct obstruction. Look at the parasagittal image, and you can actually see that the sac and the nasolacrimal duct are separated because of this implant, which is impinging between the sac and the duct. And that is what caused the SALDO, or the nasolacrimal duct obstruction in this situation. So this will also help us understand the reason and then tailor our management according to what we are seeing on the scans. Now, this was a patient who presented to us with a failed DCR, which was done elsewhere. Now, why is this important? Because here the DCR was done so badly that only a very small portion of the superior sac actually remained. So this is the canaliculus. This is a small part of the sac, and this is a small part of the sac which is left. But inferiorly, where the osteotomy is patent, there is actually no sac tissue. It's completely destroyed. And when we actually went in, there was only a very small portion of the sac here which we could salvage. However, since the common canaliculus was connected over here, we could still get a good outcome in this patient. Now, this is a patient, so over here is when we, especially in our setup, a lot of patients come in from villages who have a history of lacrimal surgery done 10 years ago, 15 years ago, and they start complaining of epiphora, but they are not sure what surgery was done. Now, the one way that we used to make sure that it is not a DCT versus DCR was ask a meticulous history, but sometimes the history is not really yielding because the patients don't remember anything about the surgery or anything that was done 10, 15 years ago. In this situation, also a CT DCG can help us, where it will show us that there is really no sac tissue inside, and there was a DCT which was done earlier, and therefore we do not really need to intervene in these kind of cases. I think we've had enough examples. Digital subtracted MR DCG is something that we've already discussed. So let us just move on to the last part of the talk today, that is Dacryocystoscintigraphy. Now, this was started by Rosamondo et al. In 1972. Now, it was mainly done for functional epiphora. It is a non-invasive test. Why is it more accepted in a lot of places, especially in the European continents, is because the radiation exposure as compared to a DCG is much less in a dacryoscintigraphy. That is somewhere between 0.014 and 0.021 rads in normal functional epiphora. But if there's a complete obstruction, the radiation exposure is slightly on a higher side. How do you do dacryoscintigraphy? A drop of technetium 99M per tectonate is instilled in the lateral cul-de-sac. The patient is sitting upright in front of a gamma camera. Every minute, photographs are taken serially for about 20 minutes. And then we evaluate whether there is a pre-sac problem or a post-sac problem. So this is how a dacryoscintigraphy looks like. So if you look at the first image, they will actually mark the lateral canthus, the brow, and the tip of the nose. So these 3 points are going to remain constant in all the images: the lateral canthus, brow, that is the glabellar region, and the tip of the nose. And these 2 points which you see are actually the canalicular, is the dye that is exiting through the canaliculus. So every minute a picture is taken, or every 30 seconds a picture is taken. So at 2 minutes, you can see in the left nasal cavity, the dye is actually now approaching towards the tip of the nose. And in the right nasal cavity, it is slightly slower. And at 5 minutes, you can see the dye actually exiting in the right nasal cavity. So this was a small 5-year-old boy who complained of right epiphora. So here there was some delay that was happening in the post-sacral region, because it did reach the sac. But however, for it to reach the inferior meatus, there was a lot of time that was taken. So a probable diagnosis in this case could be a nasolacrimal duct stenosis, but we don't know. And because of this ambiguity, dacryoscintigraphy is not really practiced, but it does give us valuable information when required. Right? Thank you.
Thank you so much for such an extensive covering of all the topics over here. So I'll just proceed to the questions which were asked on our social media platforms, ma'am, if that's okay.
Yeah, please proceed.
So one of the first questions is the clinical findings to keep in mind to indicate atonicity of the sac, since the Jones test is not frequently done in OPD procedures. So what are the syringing findings which we can come across when there is which can indicate towards an atonic sac?
Okay, so when we are looking at atonic sac, one is when you press on the lacrimal system, you may see a Rho+ positivity. Sometimes you will see an air regurgitation. That is when when two people have already done Rho+ before you, and you're seeing the patient say 10-15 minutes after that. You can sometimes, when you press that, you will see, and you can actually hear that crackling sound. So that is that air regurgitation that may indicate a sort of atonicity which is developing. On irrigation, when you're irrigating, again, do it very slowly and just observe this area. You will see that there is a small swelling which is starting to appear in the lacrimal sac area. So that will indicate that there is a possible atonicity. The other thing is the patient will not really appreciate anything in the throat immediately. Maybe when you're syringing, once you've completed 1 ml and then again you're taking it, and because nothing is really coming out. So you will repeat the syringing. And at that point, when the patient starts appearing, appreciating the fluid in the nose is when you know that there is atonicity. The other way is when you're seeing the swelling, you press on the sac. Now you will see that the patient is saying, oh, now I feel the fluid is in my throat. So all these are signs of atonicity.
Thank you. Now coming to the next question, which is a very common dilemma which we face in the clinics when a cataract surgeon refers a patient to us because the patient is complaining of watering. So sometimes when you do syringing, the patient feels water in their throat, but at the same time, there is regurgitation present. So in these cases, what is the advice should be giving?
So firstly, examine whether you've done the syringing properly or not. Most often than not, because we also see a lot of referrals in our clinic, most often than not, what we call as partial obstruction is not really an obstruction. Our syringing technique is wrong. So make sure that the technique is correct. Make sure you're not really forcing the fluid inside. When you're forcing the fluid, a little bit will regurgitate out because the capacity of the lacrimal system is not that great. It's a very small system. Imagine it's just a 10 millimeter sac and you're forcing so much amount of fluid with so much force inside. It's not going to accommodate it, right? So you have to push it slowly. So take a straight cannula, make sure you're in the sac before you're pushing the fluid. That is, you get a hard stop. Once you have a hard stop, you slowly push it like we push it in spurts. So one small spurt, second small spurt, third small spurt, and then you look at the regurgitation. If there is no regurgitation, no problem. If there is very minimal regurgitation, I think 10 to 20% regurgitation is acceptable. I don't think you need to do anything. But if there is more than 50% regurgitation, then I would say endophthalmitis, to avoid endophthalmitis, it is always better to do a sac surgery. One way to evaluate is to do a DCG and see if what we are looking at is normal or not. If the patient is not affording, directly take the patient up for DCR surgery. The one more important thing that you can look at is in the regurgitated fluid, look for mucoid flakes. So if there is any mucoid flake, white flaky material that is coming out in the regurgitated fluid, that means you're looking at some sort of obstruction. So in that situation, always go ahead with DCR before cataract surgery. If there is no mucoid flake, there's very minimal regurgitation, I think it's safe for the patient to undergo cataract surgery.
Thank you so much. And there's one more question. In case of supernumerary puncta, is there any specific, the medial or lateral most to choose from while doing syringing, or is it either can be?
Both of them will actually have the opening into the same canaliculus. With whatever you do, it doesn't really matter. And having a supernumerary puncta doesn't really say that you have to do something to manage that, because really nothing needs to be done. It's just an anatomical defect. And there may be a little bit of epiphora due to lacrimal pump function issues, but that epiphora is negligible. It generally doesn't cause any epiphora.
Okay, ma'am.
Yeah.
There's the last question regarding the terminology of partial NLDO. Is it based on a specific clinical finding, or is it just on a syringing basis that we consider them as partial NLDO or complete NLDO?
So from a practical perspective, a partial NLDO is purely on basis of syringing and the amount of regurgitation that you see. So if you're seeing regurgitation, so we write it as say 20% regurgitation partial NLDO. But you cannot really call it an obstruction unless you've evaluated it, right? A partial regurgitation can be because of a dacryolith or a mucopeptide concretion, as it is called nowadays, or it can be because of stenosis in your lacrimal drainage passage. You really don't know at this point in time. So whether to call it an obstruction or not, it's a misnomer. I would call it a misnomer. You need to evaluate more why that partial regurgitation is happening. So I would call it a partial regurgitation more than a partial NLDO.
Thank you, ma'am. Thank you so much for covering this topic so extensively, and especially considering syringing is a procedure which we commonly do in our OPDs, and we have got to know the proper technique to do it now. And I would like to make an announcement regarding our next iFocus schedule. We will not be returning on the next scheduled day on Friday, but we'll be returning 1 week later with Dr. Javed Ali speaking on diseases of the puncta. So I hope all of you join us that day again. It'll be great if ma'am you could join us too. And once again, thank you so much for covering this topic so beautifully and helping the postgraduates so much through this lecture.
Thank you. If there are any questions, anyone can just mail me. My mail ID is there on the LV Prasad website. So in case if you cannot find it, then you can find it there. Thank you. Thank you, everyone. Thank you.
Thank you. Thank you so much.